Good afternoon from Seattle. My name is Jens Chapman. I'm a spine surgeon at the Swedish Neuroscience Institute in Seattle, Washington. I'd like to introduce my partners here to my left.
Hi, everybody. Rod Oskouian from Seattle at the Swedish Neuroscience Institute.
He's our chief of our spine service. And to my right,
my name is Thomas Schildhauer. I'm from Bochum, Germany.
Thomas Schildhauer is the chairman of the Department of Surgery there, and he has created a very novel neuroscience rehabilitation unit there for his injured patients, spinal cord injured patients. We're very proud to host this session this afternoon on behalf of the Seattle Science Foundation in conjunction with AO Spine North America, the Rick Hansen Institute from Canada, one of the leading spinal cord injury research organizations in the world, and ICORD from Vancouver. We're extremely privileged to have an all-star faculty together. From Toronto, we have Professor Michael Fehlings, Vice Chair and Chief of Research in the Department of Surgery at the University of Toronto. We have Dr. Jim Harrop, Professor and Co-Director for Adult Reconstructive Spine and Chief of the Delaware Spinal Cord Injury Center from the Jefferson University in Philadelphia. We're also very privileged to have Professor Shekar Kurpad from Wisconsin. He's a professor and interim chairman of the Department of Neurological Surgery and director of the Spinal Cord Injury Center there. And last but certainly not least, Professor Brian Kwon. He's the associate director and clinical research director of ICORD and the director of the Vancouver Spine Research Program. We thought we would ask these leaders in the field to briefly present 4 major topics of spinal cord injury research. Dr. Fehlings will talk about where we are with pharmaceutical trials in spinal cord injury. Dr. Kurpad will talk about where we are with neuroimaging of spinal cord injury. Dr. Kwon will talk about biomarkers in spinal cord injury. And Dr. Harrop will talk about an important surgical aspect for one of the incomplete cord injury syndromes, that is the role of surgery. There's no question that spinal cord injury is one of the leading problems in terms of paralysis and disability. And like tumor disease, it leads to great frustration on the part of patients and families. It is estimated that about 3 million patients in the US who have some form of a paralyzing disorder, and there are no immediate cures available, despite what media sometimes says. I'm not going to ask to read this, but basically these are just some of the breakdowns of some of the major causes for paralysis that are currently unsolved. So the big question that we're going to ask of these leading eminent colleagues is how close are we to curing spinal cord injuries? Where are we and what are the blocks? And maybe, just maybe, by spreading this message around the population at large on the web community, we can raise awareness and kind of congeal efforts so we can make tangible, real, meaningful improvements for our patients. And this is, again, a direct messaging to our patients, hopefully without the media directly kind of distorting or hyping up messages. So with this, and without much further ado, I'd like to ask Professor Fehlings to talk about where we are with pharmaceutical trials in spinal cord injury, and are there pharmaceutical options for treatment. Michael?
Good evening. It's a pleasure and privilege to be part of this symposium on acute spinal cord injury, and want to thank the Seattle Science Foundation as well as the other partners. I'm going to give a brief update on where we are with neuroprotective trials in acute spinal cord injury, with particular focus on the Riluzole and spinal cord injury trial, which is sponsored through AO Spine North America and a number of other partners that are shown on this slide. I've no commercial disclosures. This work is funded by a number of agencies that are listed on this slide. This slide just gives a brief snapshot of where we are with some of the emerging neuroprotective strategies for acute spinal cord injury. The 2 drugs listed at the top in green are both currently in randomized controlled trials, and I'll talk in some depth on Riluzole, and we'll cover some of the other topics in briefer detail. Riluzole is a sodium glutamate antagonist that's currently approved for use as a neuroprotective drug to slow down the rate of nerve cell degeneration in ALS. And this is currently in clinical trials through a collaborative effort through AO Spine, the Christopher Reeve Foundation, the Rick Hansen Institute, as well as the Ontario Neurotrauma Foundation in acute spinal cord injury. Minocycline is a tetracycline analog, and it's also a matrix metalloproteinase inhibitor, and through its anti-inflammatory properties has been shown to have some neuroprotective properties, and this is currently also in randomized trials. GCSF is a pro-inflammatory cytokine that mobilizes mesenchymal stem cells, and this is used as a rescue therapy in cancer chemotherapy, and it's being studied by Japanese neuroscientists in the context of acute spinal cord injury. The Miami group is championing the use of systemic hypothermia in acute spinal cord injury, and this is now being translated in early phase clinical trials. The two compounds at the bottom of the slide, magnesium PEG and FGF2 analogs, were in phase 1 trials in the last few years, although these trials have been stopped. The concept of neuroprotection is based on the idea that acute spinal cord injury involves both primary and secondary injury mechanisms. On the left is shown a post-mortem mid-sagittal image of an individual who sustained a traumatic fracture dislocation of the mid-cervical spine, and it shows the violence and the primary injury involved in an acute spinal cord injury. The ongoing compression and the ischemia that's in the spinal cord evokes a cascade of secondary events that's referred to as a secondary injury. And this is shown schematically on the right as a series of positive feedback loops that emanate from the ischemic injury. And in particular, there are ionic shifts that occur at the level of the cell membrane, including influx of sodium and calcium and release of glutamate that trigger programmed cell death. And this is really the focus now of a number of neuroprotective strategies. The concept of neuroprotection is also predicated on the idea that we have interventions that can show a difference. One of the principles that's emerged in the treatment of acute spinal cord injury is the concept that decompression of the acutely injured spinal cord and stabilization of the unstable spinal column optimizes the milieu for recovery. The surgical trial in acute spinal cord injury study is one of the pieces of evidence to support the concept of early surgery. And the Staskis trial showed that with early intervention, patients with cervical spinal cord injury had a significantly improved odds of showing neurologic recovery. And early decompression of the spinal cord is now one of the key principles that's being used to optimize the management of patients with spinal cord injury. But importantly, this also optimizes the milieu for recovery and makes neuroprotective strategies increasingly feasible. So minocycline, as I'd indicated previously, is a tetracycline analog, and it also is a matrix metalloproteinase inhibitor. It has an anti-inflammatory compounds. And in an early phase 2 placebo-controlled trial, Kasha and colleagues showed some promising results in acute spinal cord injury. These are summarized here. The bottom of the slide showed that, in particular in patients with a cervical spinal cord injury, there were some promising trends, although these were not significant, toward improved recovery. And based on this, these promising results, a phase 3 trial is now moving forward with minocycline. And this is focusing on acute cervical spinal cord injury. It's a multi-center, double-blind, randomized trial, which has started with a planned enrollment of 248 patients. Granulocyte colony stimulating factor, or GCSF, is a treatment that's used in cancer chemotherapy as a rescue for a chemotherapy-induced neutropenia. And this drug stimulates granulocyte production, differentiation, and survival. But importantly, in the context of neurotrauma, it mobilizes bone marrow stromal cells And these target the acutely injured spinal cord, and this can enhance neurogenesis, reduce apoptosis or program cell death, and promote tissue sparing. And based on this, this is now moving forward in phase 3 randomized trials in acute cervical spinal cord injury, and these studies are being pioneered in Japan. This slide shows the results of a recent systematic review and meta-analysis of animal models in which therapeutic cooling was used in animal models of spinal cord injury. And in the gray, this shows that there's overall a positive beneficial effect with cooling. And this includes both local cooling and systemic hypothermia. And based on this, the Miami group is proposing a trial that they've called the Arctic trial, the acute rapid cooling for traumatic injuries of the cord. And they're proposing to do a prospective multicenter trial of moderate intravascular hypothermia. And this is currently in the planning phases. And my understanding is that this group has recently received DoD funding to do a small pilot randomized trial. The role of sodium in spinal cord injury is supported by a wealth of basic science evidence, and this provides the evidentiary basis for looking at Riluzole, which is a sodium channel blocker. The evidence is summarized schematically in this film. Here we're modeling a subaxial cervical burst fracture. It results in a primary injury to the cord, which is amplified through the processes of secondary injury. In the white matter, and we focus at the nodes of Branvier, we see that there's an influx of sodium through voltage-gated sodium channels, and this results in cell swelling. And then there's calcium entry through reverse operation of the sodium-calcium exchanger. And in addition, there's triggered glutamate release, which provokes excitotoxic cell damage. And so the constellation of these events, sodium entry, reverse operation of the sodium-calcium exchanger, and glutamate release, triggers secondary injury and cell death. So in the RISCUS trial, or the Riluzole and spinal cord injury trial, we're focusing on cervical injuries. Patients are having early surgical intervention to optimize the milieu, and then they're receiving Riluzole, a sodium glutamate antagonist. This binds voltage-gated sodium channels. Sodium entry is blocked. It inhibits reverse operation of the sodium-calcium exchanger and reduces glutamate release. And thereby, the hope is that this will promote significant neuroprotection. This work is based on a strong evidentiary basis of support in animal models, but is also supported by a promising phase 1/2a clinical trials results. And this work has been supported through a consortium involving AO Spine North America, AO Spine International, the North American Clinical Trials Network, which is the Christopher and Dana Reeve Foundation Clinical Trials Network, and this is supported through a U.S. Department of Defense grant. And more recently, we brought on other partners, including the Rick Hansen Institute and the Ontario Neurotrauma Foundation. And this article, published in the Focus issue in JNS Spine, outlines the rationale for the use of Riluzole in acute spinal cord injury. In the phase 1/2a trial, we enrolled 36 patients with cervical spinal cord injury, and we had 36 matched controls in a prospective controlled cohort study. We looked at both thoracic and cervical injuries, though 78% of patients did have a cervical injury. And we looked at patients with Asia A, B, and C injuries, and the majority had either motor vehicle collisions or falls. And this is the consort diagram just showing the design of the trial with the 36 Riluzole subjects and 36 registry controls. Patients had surgical intervention, and the majority had surgery within 24 hours, with a mean time to surgery of 17 hours. And this included both the cervical and thoracic patients, with the cervical patients having surgery within 24 hours as a uniform standard. This looks at the complication profile and a comparison between Riluzole and the registry cohort. And we found that Riluzole did not increase the rates of complications. And in fact, there's a suggestion for potentially slightly reduced cardiovascular complications. This slide illustrates the effects of Riluzole on promoting a conversion on the Asia Impairment Scale grade. And these patients have all had surgical intervention. So this is the additive effect of Riluzole to early surgery. And here we find that for Asia A, Asia B, and Asia C subjects, that there was about a 20 to 25% relative improvement in the Asia conversion rates. And these results were statistically significant and are quite promising. If we look at the cervical injuries as a subset, we find here that there is an improved trajectory of recovery of the motor scores over time. So with this evidence of safety, feasibility, and potentially promising neurologic results, we've established the feasibility for a multi-center trial evaluating Riluzole in traumatic spinal cord injury. This is the publication from the phase 1/2A trial. The RISCUS trial, or the Riluzole in spinal cord injury study, has received FDA clearance from the Canadian and Australian authorities and is now moving forward as a partnership with the organizations listed on this slide. And to date, 46 subjects have been enrolled, and we're continuing to recruit additional sites. There are several key design elements in this trial which make it of very high quality. This is a prospective, double-blind, placebo-controlled trial. The primary outcome measure is a change in the Asia or INSCI motor scores from admission to 6 months. We decided to focus on cervical spinal cord injury because we felt that this is where the greatest effects will be seen, and cervical spinal cord injuries represent the injury with the greatest degree of impairment. This is a sequential trial design with an adaptive sample size adjustment with an interim analysis at 2/3 enrollment, and there will then be the opportunity to adjust the sample size based on the results of the studies. This is a unique design element. This is a 1-to-1 randomization scheme. Patients receive a loading dose of Riluzole for 24 hours and then a steady state dosing for the following 13 days to complete a 2-week course of Riluzole. And there's a planned enrollment of 351 patients. We're looking at patients who have an INSCI or Asia impairment scale of A, B, or C with a level of injury of C4 to C8. And these are blunt injuries, and we're not looking at penetrating a trauma. So this is, in a nutshell, is a summary of some of the promising neuroprotective trials that are moving forward. And we've really entered a new era of regenerative neuroscience, and where we're seeing the translation of promising therapies into the clinical arena. There are a number of promising strategies that are being examined, and I'm particularly hopeful of the with regard to the RISCUS trial, as the effects in both the animal models as well as the early phase trials are showing significant promise. Thank you very much.
Thank you, Michael. Great presentation. I want to introduce my colleague, Thomas Schildhauer from Germany again. He had a question to you.
Hi, Mike. Coming from Germany, I'm wondering why is it, or is there a problem to recruit, to enroll patients? Coming from Germany and seeing and knowing the situations here in the States, I would expect that you would be able to include much more patients during the time frame of 2 years. Is this a funding problem, or is this a problem with volunteers to be included?
Well, acute spinal cord injury is a challenging area to recruit, and we have a number of challenges. One of which is the time window of recruitment. So the patients need to receive the drug within within 12 hours. Realistically, although we started the trial 2 years ago, we have had significant initial challenges with the startup of the trial related to regulatory issues and IRB approvals and contracts and so on and so forth. But now the recruitment is picking up, and we're bringing on additional trials. And I think this is a phenomenon where it's recognized that this is a particularly challenging patient population to recruit into. But I'm quite hopeful now as we bring additional centers on board, and as we've had the experience of having run the trials, that the recruitment will continue to pick up.
It's interesting. There's two problems, I think, with the acute recruitment of patients in spinal cord injury programs in the U.S. The first is, which is a good problem, is that the numbers are decreasing. And it's interesting, if you look at spinal cord injury as a bimodal peak, we're actually seeing a lot more patients in the elderly group, which are falling out of the age groups of enrollment or getting into the trials, meaning that the average age of spinal cord injury in the last 20 years has gone from 20-year-old to 40-year-old mean, but that means that the elderly group, because of the baby boomers, probably can't get in the Riluzole trial because they're over the age group of, I think the enrollment, Michael, you can correct me, is 75 years old. So if you're 76, which is a lot of the age group that we're starting to see now, they can't get into these earlier trials. So that's the first problem. And the second problem is kind of a little bit more of a depressing problem, is that spinal cord injuries become a business. At least in the recruitment centers that we see, that a lot of the sites that probably don't have as great of facility and management and care capabilities are holding on to the spinal cord injury patients because it's a very positive DRG for the hospital. And so we don't see transfers from a lot of other facilities. And I think this is becoming more common than it was 20 years ago.
Shekar, thank you for joining us. At the University of Wisconsin, how often do you see spinal cord injury patients having perfect initial treatment in terms of just fulfilling the basics, like blood pressure, oxygen, getting them maybe cooled down, getting them immobilized, getting them to the right place in time? Are these kind of elemental ABCs well performed and executed?
Thank you, Jens. So that's a great question. I think so. So my answer to that question is sort of segues into what Jim just said. So if the patients were to come, for example, to our institution, which has a long-established spinal cord injury center, it's a model center, etc. Those ABCs that you mentioned are usually handled extremely well. But as Jim just said, we are also in Wisconsin seeing a lot of patients, especially in the central and northern parts of the state, Upper Peninsula of Michigan, et cetera, geographically, historically great referral spots or for transferring spinal cord injury patients into our system that are tending to keep those patients for the initial surgical stabilization procedure, et cetera. And so we often don't see them nowadays, or at least see them much less commonly until about a few days have elapsed. So in the acute setting, I think in a quaternary care center with an established spinal cord injury infrastructure, the attention to those variables is excellent. But the same can't be said where some of these patients are increasingly being treated.
Jens, this is Jim Harrop. I just want to add on to that. And I think the third part of the equation, which I didn't mention, we actually wrote a paper and we looked at trauma transfers through the Pennsylvania Trauma Foundation. That includes all the trauma level 1 centers in the state of Pennsylvania. It was very interesting because people seem to think spinal cord injury is not an emergency. And so one of the take-home messages I think people would get out of this webinar is that spinal cord injury needs to be treated just like an acute stroke. People need to get and receive therapy instantaneously. And what we found out was that the acute abdominal injuries got to the ER first, the head injuries came in second, and then a staggering third came in the spinal cord injuries, typically over 8 to 12 hours, which would, most of these patients would not be able to be eligible in any spinal cord injury trial.
Brian Kwon, you heard the problems that we face in the U.S. America, funding, not such an organized trauma response system, maybe a little selfishness. How does that resonate with our neighbor to the north, based in Vancouver, British Columbia, with a very good government funding, a very organized data gathering system, and maybe a little bit of more regimented kind of an approach towards healthcare problems like spinal cord injury?
Well, thanks, Jens. I think that the reality is that our systems are potentially a bit more centralized, but I think we also experience some of the similar difficulties as what Jim described. Perhaps not to the same extent, but and potentially not with necessarily the same financial motivations. I think that we have traditionally enjoyed a good referral system in our province where all spinal cord injuries come to our center, and for the most part, I think that has been maintained. I think that what Jim described as the changing demographic we've certainly witnessed that. I think one of the main issues that that plagues the trials is that there's a big difference between a center that receives a lot of acute spinal cord injuries and a center that has the infrastructure to actually enroll patients at an early time point and get all of the necessary evaluations done and assessments done at a very early time point to get that individual enrolled. And I think what we witness is there is a big distinction between simply having a lot of individuals enroll, or a lot of individuals that get admitted to your hospital, and having the actual personnel in place to conduct the trials.
Thank you, Brian. I want to close this segment inviting Dr. Fehlings for a closing comment. And Michael, if you had 3 wishes as lead investigator of the landmark Riluzole trial, what are your 3 top wishes?
To have the continued support of our various collaborators, and to believe in us that we're going to be able to achieve a successful trial, to be able to convince other funding bodies to join collaboratively in the trial, because this will enable us to bring on other centers to facilitate the enrollment. And ultimately, it's my dream to take this trial at an international level, because spinal cord injury truly is an extremely disabling condition that is particularly of major relevance in areas of the world that are less developed. Finally, I really feel that in the next 5 years, we are going to have one or more pharmacological treatments which will ameliorate the devastating effects of acute spinal cord injury.
For the public, and in closing, I think I have the agreement of Dr. Schildhauer here to my right. You, Michael Fehlings, and your collaborators deserve tremendous credit, because although we don't have the secret agent yet, the fact that you've brought all these centers together, and all these cities, all these countries, and all these great organizations beyond individual pride deserves great recognition. And I think that alone is a monumental advancement in fighting spinal cord injuries. Do we all agree?
Absolutely.
Thank you, Michael.
That's very gracious of you. Thank you.